Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as the program moderator for tonight. Back and neck pain are common conditions for many people in our region. This informative webinar will cover a wide range of topics, including the causes of back and neck pain, the different types of spine conditions, non-surgical and surgical treatments for back and neck pain, and the latest advances in spine care. Well, thank you all for submitting your questions in advance of tonight, and the questions that you will hear me asking the panelists are all submitted questions right from when you registered for this webinar. And if you have any questions throughout the discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Well, with that, I want to go ahead and introduce our experts for the evening. So I will have each one of you give a little background information about yourself. So let's get started. Dr. Christian Holscher with neurosurgery and spine surgery. Welcome tonight. How are you doing this evening?
I'm doing great. Thank you for having me. I had the pleasure of being here I don't remember the third or fourth time, so I've done this a few times, enjoyed it, and happy to be back. Thank you for that introduction. I'm Christian Holscher. I did my training at Jefferson in Center City, and I've been in practice now in South Jersey it's my fourth year now. And so I cover, my practice is based in Washington Township, but we also cover Cherry Hill and Stratford and kind of the South Jersey area. And if you're in that area and looking to have anyone to talk to about spine or anything related to neurosurgery, we're, certainly happy to see and happy to be here tonight. And thank you for having me.
Absolutely. Thank you for joining us again. We're excited to have you back. Okay, well, next we have Dr. Mark Katupka with neurosurgery and spine surgery. How are you doing this evening?
Fine, thank you.
Good. We're excited to have you.
So I'm currently work at Jefferson Einstein. I've been there since 2000. Prior to that, I was at the University of Pennsylvania for approximately a decade, which is where I trained to do the full breadth of neurosurgery. But certainly, as will come through this evening's discussion, the vast majority of what neurosurgeons see in our country is related to the spine. So this is very pertinent and appropriate for this evening's conversation.
Absolutely. Well, thank you for joining us. Okay, next up we have Dr. Srinivas Prasad, neurosurgery and spine surgery. Welcome.
Thanks for having me, Sarah. That was great pronunciation, by the way. My name is Srini Prasad. I've been at Jefferson now for over 14 years. I'm in my 15th year now, which is hard to believe. My training is all over. I trained at Hopkins in Baltimore, and then Washington University in St. Louis for neurosurgery, and then Cleveland Clinic for my spine fellowship. My practice is almost 100% spine. I do a little bit of cranial stuff when I'm on call, but really I specialize in complex spine surgery. I have primarily been in practice in Center City. I do operate in Center City 2 days a week, but I also am in Langhorne, where a big part of my clinical outpatient practice is. And so I see a fair number of patients from the Northeast and part of Bucks County and so forth. I do clinic in Langhorne and do a lot of cases in Langhorne and Center City. Thanks for having me. I'm excited to be here and excited about the conversation.
Yeah, absolutely. We're excited to have you. Okay, and finally, welcome Dr. Tarek Yassin with neurosurgery and spine surgery. How are you doing this evening?
Hey, Sarah. Thanks for having me. I'm very glad to join you for the first time. I've been with Jefferson officially since September. I'm dual trained in functional neurosurgery from the University of Colorado, and I just finished in August my complex spine fellowship from Jefferson. I'm located at the Jefferson Northeast, mainly at Torresdale, but should be doing cases as well at Langhorne, basically at the Northeast.
Okay, great. Well, we're excited to have all of you, and I know that we have a great discussion ahead of us as we've had a ton of submitted questions already. So thank you. Okay, so without further ado, let's dive in. Dr. Holscher, we will turn to you for the first question of the night. What are the latest treatments in spine care, both surgical and non-surgical?
Well, that's a huge question. Like, you could probably dedicate an entire webinar series to that. And so it's really a broad question. And so there's not going to be a clean, kind of cookie cutter answer to that. When I think about that question, I would say, and in this panel, we have 4 neurosurgeons. Like, our focus here is all going to be on the surgical side of things. Like, I think if you really want to have an in-depth discussion about the non-surgical side of things, like, it's probably best to have that discussion with physical therapists and neurologists and pain management doctors. From the surgical side, the way I approach that question, I had the pleasure of being on this panel with one of my mentors, who was Srini Prasad, who's on this, this webinar. We used to always think about cases in certain very solid constructs, like what are the goals of surgery? And so the goals of surgery from yesteryear to today, that discussion doesn't change. Like, your goals of surgery in some way are to decompress nerves or to stabilize the spine or to promote fusion. And so innovations or changes in surgery, it's not like we have new and different surgeries in that sense. Like, the goals of surgery don't really change. It's more like, how do we kind of go about that, or how do we approach that? And how do we achieve those same goals in newer, innovative ways? And I think that's probably the best way to think about that question. And there are so many different ways to think about that question. One is just technique, right? The more, as things progress, I think we all have some goal towards trying to minimize the invasiveness of surgery. And surgery is itself in some way an invasive thing, right? There's no way to get around that. But can we make incisions smaller? How can we approach the spine and do things that involve less soft tissue injury or collateral damage? And sometimes that is appropriate and sometimes it's not, right? And so there are some patients, for example, that are candidates for less invasive decompressions or less invasive fusions, and other patients that just frankly are not. Other innovations that we use in the operating room tends to be geared more towards equipment and tools that we use in the operating room. There are so many different types of equipment and tools that we use. So, for example, bringing imaging into the operating room, right? Whether it's 3D X-ray or intraoperative CAT scans, sometimes even intraoperative MRIs, to kind of give you real-time feedback for your surgery in terms of whether it's a tumor decompression or whether it's instrumenting, placing hardware in the spine. And other tools that we use. Robotics is often a term that comes to mind. A lot of people ask about robotics, and I think people have kind of, the conception that people have of robotics in surgery is a little bit science fiction, right? They envision some, android that's helping us operate, and that's really not what it tends to be. Like, robotics tends to mean tools that are more extensions of the surgeon's arm that help you do things more efficiently or with more accuracy. So, for example, in spine, it tends to be robotic arms, for example, that may help you place instrumentation or screws into the spine with more accuracy in really challenging spines where the anatomy may be distorted, either by deformity or by prior surgery. Other implants or hardware. We use a lot of hardware and implants, particularly in spine, and there's tremendous innovation that goes into all of those things. It can be the screws and the rods and the cages that we use, that we pack with bone graft, the material that they're made of. How well does bone grow into it? How well does it promote bony fusion? How much artifact does it create on imaging? Like, how easy is it to get an MRI and see what we need to see when we've put a bunch of hardware in there? There are some tools we can use to limit the hardware artifact on MRI. Tools that we use, like the types of bone graft that we use to promote fusion, tools that we use to help treat and manage complications like spinal fluid leaks. Like, there's so many different facets to innovation and treatments. And I would argue that, frankly, like the bare bones of the surgery itself, like what we're trying to achieve over time, doesn't change. It's just, how do we approach it and how do we deal with that? And that's such a varied problem, and like that has so many different things that go into it. There's no cookie cutter response to say, this is what we do today that is different than what we did yesterday, because that from patient to patient it changes, and it can vary very much. Kind of as a lead into your next question, and I can see here, which is about how effective are these tools? Like, that's a really very vague question. It's like, I don't think any surgeon would ever recommend a surgery where you'd say, well, I don't think this is going to be very effective, right? Of course, if you don't think it's effective, you wouldn't do it or recommend it, right? So anytime you go into surgery, you go into it with the thought of like, this is going to be a durable, we expect some kind of durable response. And unfortunately, sometimes that doesn't turn out to be the case. But, any surgery that you're recommending is always thought of and constructed in that framework of what are the goals of surgery, right? And if you're achieving the goals of surgery, for that patient that you expect to create benefit XYZ, well, then you expect it to be durable, you expect it to be reliable. And so I don't think that there's an easy answer to, how reliable or durable is it. It's just, every patient is a bit different. We have to think about, I'm sorry, my dog is barking in the background here. But we have to think about every patient a bit differently. And I would just argue that every patient is a bit different. No two patients are the same. And it's really difficult to give you kind of a concise answer to that question.
Yep. And they're certainly complex questions. So thank you for walking us through that. And just so you know, we can't even hear your dog, so you're good. All right. Well, with that, we'll go ahead and move on to the next question for tonight. Dr. Koptupka, this one's for you. Can you talk a little bit about what are some of the main causes of back and neck pain? Maybe another kind of general question here.
Yeah, and that's a great question. And that's sort of the holy grail of what all of us do here, right? In terms of trying to help people, is identifying what that cause of the pain is, because it's so variable. There are some big ticket items that we all hear about. The person who breaks their back or breaks their neck in a terrible traumatic accident, the person with a tumor, the person who has an infection in their spine. Those are sort of the big things that get headlines in our world. But the vast majority of folks who see us, it's with what we lump into that waste bucket of degenerative spine conditions, arthritis, as people would say. And that can occur in a 30-year-old. It can occur in a 60-year-old. I mean, it doesn't respect age. It just respects use of your spine. And that's what the biggest bucket of patients that we see, and yet that being able to do that detective work in terms of figuring out, all right, so what in this individual, what is the cause of that pain? Is it a single disc that's degenerated? The discs, the cushions, the cartilage between vertebrae. Is it a problem with stability related to something that was congenital, that was silent for 20 years, 30 years of their life? So the first part goes into that detective work, and that depends so much these days on imaging. I mean, we depend so much on MRI, CT, and other imaging modalities to try and direct what can be done in terms of establishing the diagnosis and then figuring out the course of treatment. So that's a simple answer to a very complex question, actually.
Yes, absolutely. Well, thank you for narrowing that down for us. All right. Moving along, Dr. Prasad, this next question is for you. What is the best way to approach degenerative disc disease?
Yeah, great question, Sarah. Thanks for the question. I think of the spinal column, well, the spine, we're all spine surgeons. There's really two principal components. There's the spinal column, which is the bony structural skeletal component to the spine. And then there's the neural elements, which is the spinal cord and the spinal nerves. And they live kind of intimately related. The spinal cord sits inside the spinal canal, kind of wrapped in bone. So the spinal column is a stack of blocks. You can think of it as a pillar or a flagpole in a sense, but it's made of different segments, and there's 24 total in the mobiles from the neck down to the lumbar spine. Between each of those blocks is a cushion, which we call an intervertebral disc or a disc. So when people say I had a disc herniation or disc disease of some sort, you're referring to the cushion, which is between blocks of bone. Those cushions, I think of them as wear items. They're like tires in your car or gaskets. They kind of wear out over time, and they wear out with miles. And so some people, even at 30, as Dr. Koptupka was saying, can have a lot of degeneration. And that can be partly a byproduct of genetics, and it can be the lifestyle they've led and their weight and things like that. but these are wear items, kind of like your tires. And, you lose tread on your tires. You never stop to think, where's the tread? It's on the road someplace, and it's like, but the question is, how many miles do you have on it? So the best way to approach degenerative disc, so degenerative disc disease refers to that process of wearing out of those intervertebral discs, which can happen quite variably. We see it the most in the neck, or the cervical spine, and the lumbar spine, because those are mobile. Like, you can move your neck, you can move your low back. The thoracic spine, which is like your chest part, has ribs that support it, so it's more like a barrel. So it moves a bit, but we don't see the discs degenerate because they just don't get exposed to that much stress. So the way to really preserve your discs is to imagine that model, like your spine is a flagpole, and think that a flagpole is only as stable as the cables that hold it up. It's fine. The integrity of the flagpole itself is one question, but the cables are really important. And the cables of your neck are the muscles of your neck. The tighter, the stronger, the better those are, the more stable the cervical spine is. In the lumbar spine, your core, your abs, your obliques, your back muscles, that core strength is really important at preserving the stability of the spine and kind of unloading stress from the discs themselves. So I tell people, core strengthening, neck strengthening, that's what you can do to protect your discs. Nobody can avoid getting it. Nobody wants to get in an accident. Nobody wants to slip and fall. But if you really want to protect your discs from the day-to-day stresses or the day-to-day miles, the way to do it is to kind of work on strengthening your core, both in the neck and the low back. And things that can be good for that are things like yoga, Pilates, swimming, like things like that. You don't have to do formal physical therapy to work out specific muscles, but some of those maneuvers, like I think yoga is incredibly effective at core strength, really. So things like that can really help a lot with protecting your discs.
Absolutely. And easy to implement into everyday routines. So great to hear. Okay. Thank you. All right, moving along to our next question, Dr. Yassine, this one is for you. Can you discuss a little bit about pain management from stenosis and scoliosis?
Thank you, Sarah. Very good question, because most of the cases we see are related to spinal canal stenosis and what we call neurogenic claudication. That's when you get back pain or leg pain after a period of time when you walk or exert some stress on your back. It's a complex approach between surgeon, physiatrist, physical therapist, and pain management. We should first address the patient, know exactly what they're having from the history, if there are any red flags also concerning the physical exam that we might have to skip pain management. But basically, you should go the steps from the bottom right to the top and not just jump to the top at once. Having said that, you can start with the non-steroidal anti-inflammatory, muscle relaxant. You could advance to opioids, and these are again managed by pain management. We usually don't prescribe these medications. We see a lot of patients that come to us in the clinic asking for pain medications and pain management, and sometimes it gets into a confusion point where we have to know that we are surgeons and there are some pain management doctors. But regarding that, you could start with the most simple things, and then you could advance to injections, which consist of epidural steroid injections, sometimes a nerve block, which we call a transforaminal, just to know exactly which nerve is compressed and inject that. This could give us some diagnostic value as well. If you want to do surgery, then we would just address this nerve in case of a scoliosis, for example, instead of having a very long fusion. Again, you can just do a local injection, like where does it hurt exactly? They do an injection there. You can do some facet injections or ablations after that. It depends on the nature and the physical exam and the history of the patient, but many types of injections. And I would say at the top of the stairs, you would find the pain stimulator, which is the spinal cord stimulator. I think this is like the furthest where we could do and we could go before saying, okay, either we'll do that before advancing to a big surgery, or we did a big surgery and the patients present with what we call a failed back syndrome, where we have done almost everything, but they're still having issues.
Okay. All right. Well, thank you so much for walking us through that. We appreciate it.
Of course. And
moving
again, these could take a lot of like a whole webinar to answer, but I try to summarize it really short.
I know it's not easy when we're trying to discuss such complex subjects in under an hour. So
In
we
2-3 minutes.
yeah, exactly. It's a challenge for sure. Okay, next question here, we will turn to Dr. Holscher. Dr. Holscher, for someone in their 20s who started having back pain, how can they best take care of their back in the long run?
So yeah, good question. And by far, I think as someone had mentioned earlier, like back and neck pain impacts most Americans, impacts most people. And it's not necessarily something that is restricted to the elderly population. Like we see people all the time that are young patients that have, if you took the average, frankly, 20, 30-year-old patient and just MRI'd their neck or their low back, I guarantee you will find multi-level disc bulge and disc, early disc degeneration. You may find in some patients some fairly advanced or focally advanced disc degeneration. And that's, as has been mentioned on this panel already, is just a function of wear and tear, so to speak. It's just, it is what it is. It's some combination of genetics and then some combination of external factors like lifestyle and weight and diet and smoking, et cetera, right? There is no substitute. Like, I wish I could tell you, like, take the blue pill and everything is fine, right? Like, I would be a snake oil salesman if I told you that the answer is that simple. Especially for people that are prone to back pain, like it's good for everyone, right? But if you're looking at your family tree and like everyone in your family has had a lumbar fusion, well, then you probably should be taking a little bit more attention to your back or your neck, right? And there is no substitute, as Dr. Prasad had mentioned, to core paraspinal muscle support to your spine. So when patients come to our office, and we always tell them, like, step one for always, anyone will tell you, is always physical therapy, right? And to some extension of that can be yoga, Pilates, water therapy, et cetera. But there is no substitute to core paraspinal postural muscle support. The more support that your discs and your joints in your spine have, the less stress is going to be put on the discs and the joints. And even people who are active, I mean, certainly just, being active, being on your feet, making sure you get X number of steps per day or sports, running, whatever it is, even just being active in that regard, of course, is going to be helpful. But even most people who are active or who go to the gym regularly are probably not working out their postural back muscles, right? So we see it all the time, patients who are relatively fit, some in clinic, and we recommend PT and they say, oh, that's okay, I do a lot of exercises at home. Well, you probably don't exercise your postural back muscles. Like, I can almost guarantee you that you don't. And so there is no substitute for that. And likewise, there's no substitute. The one thing you can impact, of course, is genetics, right? And that's nothing we can do about that. But the other modifiable factors, right? And frankly, it's going to sound like a broken machine if you talk to your primary care doctor. It's the same thing if in regards to cardiovascular health or anything else. Like, there's no substitute for diet, exercise, not putting the toxins of excess alcohol and smoking and drugs into your system. That, combined with good postural paraspinal muscle support, is the best thing you can do, right? And the genetics are what they are, and you may be more prone, like some people are more prone to heart disease and arthritic conditions and whatever it is. There's nothing you can do about that, but you can do something about everything else. And it really is the same refrain that you're probably going to hear from every other doctor you go to. And it may sound like a broken record, but it really is the truth. And I don't think there's anything more complicated or mysterious to it than that.
Absolutely. Yeah, definitely a common theme among many of our webinars. So thank you. Okay, next question here. Dr. Katopka, can you talk a little bit about spinal stenosis as well as spondylolisthesis and what they are and the treatment options available?
Sure. That'll take like a few hours. So I'll try and keep it short.
Do it in 2 minutes.
Yeah. So spinal stenosis. So that canal that's been referred to, where our spinal cord runs, and then down in the lower back where the nerves that come from the spinal cord, where they run, that can become narrow. That can be narrowed. It can be congenital in basis, where you're born with a canal that's smaller than average. But in most cases, it's a degenerative process that goes on from all the wear and tear that our spine is put through during our active lives. So you'll see everybody with a degree of spinal stenosis when they get to my age or older. The question is, does it become problematic for the patient? And without getting too personal, I'll just tell you a story I always like to tell patients. It was about my father, and he had spinal stenosis, and so he could walk from his apartment to the post office, and he'd have to sit down and take a break. Then he could go back from the post office to the lunch counter and get a sandwich, and then he'd have to sit down and take a break. As long as he could do that, he was happy, and he was okay. If he couldn't, then he'd go see a surgeon. It affects most of us in this insidious way that just kind of creeps up, where we have pain or difficulty with ambulation, or with the cervical spine, difficulties with things related to ambulation, but also with our hands, with our fine motor function. And it creeps up, and it can take a big toll on folks, particularly when you get into the years of retirement. So in that group of patients, not the congenital spinal stenosis, but the folks with degenerative disease, that is probably the single most important health condition that limits function in age over 60. And that includes everything: hips, knees, you name it. Spinal stenosis has an incredible burden of cost to the patient and to the health system in terms of what it does to folks. There aren't too many things that can put you in a wheelchair, but spinal stenosis can do that. So that's the importance of it. The treatment, just to jump into that, I mean, it ranges based on the individual. It can be conservative management. It can be doing all the smart things that Christian was talking about. It can include interventions with pain management, like injections. It can include little surgeries that are designed to relieve segments that are very narrowed. It can require big surgeries that involve sort of rebuilding the spine to be able to get you over the finish line, so to speak, if you know what I mean. So it's a fascinating topic, but it's one that's important, because most of us, all of us, including on every panel on the screen, are going to have to deal with this at some point in our lives.
Absolutely. Well, thank you, and definitely an important issue, and appreciate you summing it down within 2 minutes. Impressive. Okay. Dr. Prasad, we will go to you now. Are there any new treatments for SI joint pain?
Yeah, SI joint pain, our understanding of sacroiliac, SI, first of all, stands for sacroiliac, for those of you who don't know it. The sacroiliac joints are really the interface between the spine and the pelvis. So the floor of the spine is really the pelvis, and there's a part of the spine, which we call the sacrum, which is kind of triangular in shape, where it mates. It kind of sits on top like a keystone on top of the pelvis. That joint between that triangle, or the sacrum, and the pelvis, or the ilium, is called the sacroiliac joint. And it's not an uncommon place for people to have pain from. There can be a fair amount of degeneration. We certainly see it a lot. And now our understanding of it has evolved in the last 10 years. We've always kind of known it was a problem. And honestly, when I was in training, it was like physical therapy and injections were the only real options. What has changed is how rigorously we can understand it. So, when people have pain from it, it can be in the leg, it can be in the buttock or the low back. And a lot of things can cause pain in those distributions. But to figure out where your pain is coming from, it starts with imaging. As I think Dr. Kotopka had mentioned earlier, imaging is a big part of it. The physical exam is a big part of it. And then targeted injections can be very valuable. And that is because if you get an injection to the SI joint and your symptoms get better, then coming from the sacroiliac joint, and you have something called sacroiliitis. Now, the workup has become so rigorous for it. There are very specific types of injections that you get. You have to see a specialist who's comfortable doing that. Those are usually physiatrists or pain management physicians, so interventional spine doctors. They will do injections and help verify that's where it's coming from. Patients will often exhaust non-surgical treatment, and now there are very new minimally invasive ways of fusing across that joint. the joint is not really supposed to move. It's called a nutative joint, and it's a type of joint that's like two bones come together, but they're not really expected to move a lot. They move a few degrees in a normal person. But if that becomes sloppy, that can be a pain generator. And so fusing across it is very much restoring where it should be. And those techniques now are done with navigation. They can be outpatient or one night in the hospital, and they can be very effective if that's where people's pain is coming from.
Okay. All right. Well, thank you. All right, next question. Let's go here. Dr. Yassine, we received a lot of questions about the sleeping position for spinal care. Can you just walk us through the do's and don'ts for sleeping and spine and neck care?
We really get these a lot at our clinic. And I remember last year I was with my mentor, Dr. Prasad, at the clinic. And a lot of patients were asking about the mattress, like what kind of mattress should we use? It's a very difficult question and really has no good answer. But basically, you need to maintain the axis and the normal axis of the spine, and have in mind that it has a neutral curvature, like Dr. Prasad mentioned. Like your back, lower back should curve forward, what we call lordosis, and your neck as well. And it comes from the Latin word as to be forwardly bent. So you need to maintain this posture at all times. And if you want to sleep on your back or on your side, I always tell the patients that while you sleep, you really don't know how the night progresses. Like we keep on turning, usually you're not on a certain position, but also some pain generators are indicative of the pathology, and you can get a relief. Like if you sleep in a recliner, sometimes it could indicate that you have a vertebral slip, or what we call a spondylolisthesis. If you sleep with your knees bent or flexed, that might be an indication that the sciatic nerve is stretched by a disc herniation. So the short answer for your question is to put some pillows under your knees and to avoid sleeping on your belly, because that puts a lot of pressure on the spine. And also, if you want to sleep on your side, your head has to stay in a certain position, like it has always to stay between your shoulders and not be bent to some way like this, for instance, or that your buttocks is higher than your head. You have to always maintain a normal curvature of the spine at all times.
Okay, definitely some helpful tips to keep in mind. So thank you.
Yeah, of course.
All right, Dr. Holscher, we will talk a little bit here about herniated discs. So can herniated disc in your neck and back cause dizziness, pressure, and even feeling disorientation?
I mean, I guess yes and no would be the answer to that question, right? The textbook features of degenerative disc disease would be, the degenerative disc is a joint, and so like the typical features of a degenerative cervical or lumbar disc disease are pain in that area, so neck pain or low back pain. And then symptoms that you would expect related to inflammation or compression of the relevant nerve structures that are around the disc, right? So let's just, focus on the cervical spine. That would be the spinal cord itself, or the nerve roots that come off the spinal cord. So the nerve roots that come off the spinal cord will classically cause pain, numbness, tingling, weakness, in a distribution of that nerve root. So, if your right C5 nerve root is compressed, for example, you might have pain, numbness, tingling, coming over top from your neck, radiating over the top of your shoulder into maybe the top of your bicep. Like that would be typical. It's almost like sciatica of the arm, I tell people. It's like pain in the distribution of that nerve root coming down your arm. Or in the low back, you might get similar thing, right? Pain, numbness, tingling in the distribution of that nerve root. When you have spinal cord compression, you tend to get more diffuse symptoms. And so when we talk about spinal cord compression, we're typically talking about the cervical spine. And in the cervical spine, when you have significant spinal cord compression, you're getting usually numbness, tingling in both hands, with some weakness, usually in grip. So you tend to get more vague, not vague, but more diffuse symptoms. So typically both hands feel numb. You might feel clumsy. You might drop things frequently. You may have difficulty with your walking. And those would be kind of the typical features of cervical degenerative disc disease. Now, there are patients that will report some different symptoms that sometimes get better after surgery. And those can be things like bad headaches. I've had patients that had facial pain or facial numbness that improved after surgery. Sometimes vague symptoms like dizziness. Those are not, admittedly, I don't think any surgeon that is honest with you would recommend surgery on the basis of those symptoms alone. Like typically, if you're recommending surgery, it's for the typical textbook symptoms that we just talked about. And sometimes patients do have more unusual symptoms, and we do explain that. Like I tell people, there are fibers, like there are nerve fibers that are coming down from your brain and your brainstem that do kind of mingle in with the cervical spinal cord. And so sometimes you can get more unusual symptoms, but again, they're not considered typical or cardinal features of cervical degenerative disc disease. And if your only presenting symptom, for example, was dizziness or was feeling, facial pain, or I would not recommend surgery in the hope, it would be very speculative to recommend surgery in the hopes that those symptoms get better in the absence of more typical features, being, numbness, pain, weakness in the arms, for example. Disorientation is a bit of a, that can mean different things to different people. So if you mean like in the sense that you have cognitive, or sometimes people say brain fog, again, I would tell you that's not a typical feature of cervical disc disease. If you mean that in the sense that like I'm unstable on my feet, or I feel, difficulty walking, like I have to hold on to things, I need a cane or a walker, I don't know where my feet are in space, like I feel very discoordinated, then yes, that can be a feature of cervical disc disease. That would be more a typical feature of cervical disc disease. So some of those symptoms, I would say, sometimes get better with, but again, would never be a reason in isolation where any of us would recommend surgery for.
Okay. Well, I know, you talked about surgery here. So can you just go through a little bit of the best methods for pain management and relief for this?
Yeah, and to varying degrees, I think basically all of us have touched upon that already. Like cervical degenerative disc disease is really common. Like I had mentioned a bit earlier, I can take a 25-year-old healthy person and image their neck, and I will find a multi-level disc bulge, right? So you have to be careful reading if you ever get an image of your neck or spine of any kind, right? You got to be careful reading the MRI report, because the MRI report can make it seem like much more dramatic what's going on, and it's got to be put in clinical context. Now, degenerative, the best way to treat that is always conservatively first, right? A little bit of, it's no different than having, an arthritic disc, which is what degenerative disc disease is, no different than having, and frankly, think about everything else that you hear of, whether it's tennis elbow or an inflamed knee or hip, right? You would never go running for surgery first for that, right? You take a little Aleve, a little Motrin, a little rest, you cool off. The tincture of time, frankly, is number one, right? That's always number one. And then some very simple anti-inflammatories or pain relievers like Tylenol, or the anti-inflammatories like Motrin, Aleve, ibuprofen. All right. And if pain is persistent, that can be for different reasons, right? Pain in the neck or back that is, in the midline, for example, like not radiating into your arms or legs, is likely related to some degree of inflammation in the joints, the discs and the joints in the back of the spine. And that inflammatory milieu can then extend into the nerves, which are traversing past the discs and the nerves, and can lead to inflammation of the nerve roots and can cause radiating or sciatic type pain. So sometimes, even if you don't have a big disc herniation that's causing significant nerve compression, like just the inflammatory milieu of a little bit of an acute exacerbation of mild degenerative disc disease can present like pretty significant radiating pain, like significant sciatica or a significant pain in the arm. The best, after you've kind of exhausted that initial tincture of time, Tylenol, anti-inflammatories. You may try an oral steroid, which is like a step up from the Aleve and the Motrins of the world. So a Medrol dose pack, if you've ever heard that term, is kind of the next level up of anti-inflammatory, no different than trying to cool down an inflamed hip or knee, or any other joint in your body. And when it persists beyond that, and that's usually often provided by a PCP or an urgent care, when it persists beyond that, that's when we get into physical therapy and working on strengthening the core paraspinal support. And if necessary, then taking that to the next degree, which is usually consultation with pain management, to consider injections, like targeted steroid injections. I always tell patients, like an oral steroid or an anti-inflammatory, an NSAID, a Motrin, and Aleve is great, but like how much of that pill you take gets to your left C5 nerve root? Probably 1%, right? So the purpose of a targeted injection then is to deliver that anti-inflammatory, ideally as close to as possible to where the inflammation and where the nerve roots or the discs or joints are inflamed. And then, outside of that, there are, things that are not considered standard or nobody would hold you to, but are very reasonable in certain circumstances, like chiropractor or acupuncture or yoga, Pilates, water therapy, home traction, inversion tables. There's all sorts of different things that people try, to try to alleviate some of this pain. And it's when we get past some of that stuff and we have persistent pain, that's when we start talking about, is surgery appropriate, right? Typically. Now, there are circumstances where early surgery is appropriate, and that's beyond the scope of this discussion here. But in general, for most of the stuff that most people are dealing with, that's the typical pathway.
Okay. All right. Well, thank you for outlining that for us. It's helpful. All right, Dr. Kotopka, let's talk a little bit about TMJ. Does TMJ have an effect on neck and spine health?
So I would say in general, no. However, I'm going to couch that in the sense that TMJ is a very, again, a very variable and unusual condition. First and foremost, you always have to go back to imaging in terms of making sure that the TMJ is defined as being abnormal, and in other words, and is the source of the pain that the patient is experiencing. That can overlap with some of the distribution of the cervical spine in terms of the distribution of the pain. So making sure that the diagnosis is correct would be the first step. Certainly, TMJ in principle has a lot in common with spine. I mean, it's a joint. It has cartilage. The treatment, none of us on this panel are oral surgeons or maxillofacial surgeons, but the principles are really very similar. But I think just hearing that question makes me say, question the diagnosis, because make sure the diagnosis is correct, and that will drive everything else.
Okay, great. Well, thank you. All right. We have one more question here, and then I think we're going to dive into our live questions from the audience, because I know we are getting a bunch. So thank you. Dr. Prasad, a question for you here about new technologies. So are there new technologies like robots or new treatments for spinal stenosis? And do they have any faster recovery times?
Yeah, great question. There are a lot. I mean, spine surgery is constantly evolving, like everything else, right? Like your phone now is not the phone you used 5 years ago or 10 years ago. In the same vein, I think technology does change. As Christian alluded to before, though, we start with decision-making. Decision-making really starts with people's symptoms. We try to correlate that to the imaging that they have to kind of figure out what structural causes may be causing their symptoms. Then we try to verify it, often with injections or EMG or diagnostic tests. And then we kind of set about saying, like, here's the goals of surgery. And then we talk about which techniques make the most sense. And we try to compare techniques to say, well, this technique has this benefit versus this procedure, and try to land on the optimal, not necessarily the maximal or the minimal, but the optimal treatment for a specific surgeon. So surgery plans are often very individualized. Within the context of that, technologies do enable less invasiveness. So robots are great for putting in pedicle screws. I think they will continue to evolve, and I think hopefully one day will be used for disc preparation and cage placement, deformity planning, decompression, things like that. So we could start invoking it more for other more complicated parts of spine surgery. There are tools like navigation that are used routinely now that help us understand where our instruments are in space, just like your navigation in your car tells you where you are on the road and where you are geographically. And that can be valuable, even if it's like, even if I'm driving home, it's nice to have a little supplemental, like how far am I from home? Is there traffic on the way? Like that kind of stuff. You may be very comfortable putting in screws or doing a specific procedure, but it's kind of nice to have that verification sometimes. So navigation can be good for that. Emerging technologies are things like endoscopy, which is really, it's honestly something that's been around for a long time. People ask, like, is this done arthroscopically? In the spine, we don't say arthroscopic, we say endoscopic because there is no joint per se. Arthroscopy implies that it's a joint, but the endoscopic is the equivalent. It's a small camera on the tip of an instrument that allows you to see through a porthole and kind of really maybe do more through less and cause less collateral damage. So endoscopy is something that's very exciting and emerging. And we have, and then ultrasound guided. Some people really like harmonic scalpels and stuff. There are other tools that I think those are tools that enable you to achieve those goals maybe a little bit better. The goals themselves don't change, just the invasiveness may diminish. What's important about minimally invasive surgery is recognizing that surgical selection or technique selection is a balance between invasiveness and effectiveness. Sometimes if it sounds or smells too good to be true, it probably is, we really have to weigh invasiveness versus effectiveness. And a procedure that's minimally invasive that's not effective is too invasive. That's what I tell people all the time. So we have to rely on our years of experience to say that how good am I going to be at achieving that goal with this technique. And so we try to find the least invasive, which is to say the least collateral damage way of achieving the goals effectively. All of these tools that are emerging, they will continue to emerge. We use 3D printed spacers now. That's kind of a new thing, 3D printed out of titanium. It's pretty awesome. You can get customized cages now. I have a case coming up in January where we're getting specific 3D printed cages for a specific, we send their CAT scan, they model where we want the spine to be, it 3D prints it to fit her spine exactly. That can be valuable. So there's a lot of technologies on the horizon that I think are exciting. I think seeing a specialist who's really facile with all the different dimensions of spine surgery, you can feel pretty comfortable that you would be able to leverage those technologies for you if they're relevant.
Yeah, really exciting to hear all these emerging technologies. So thank you.
Yeah, can I jump in on top of Shree's the last statement? So just to give everybody, if you haven't figured it out, you have 3 generations of neurosurgeons on the screen. And one of the things that I'd like to just let everybody know is that the basic goals have been the same since I started working and now for the younger folks who have come out. But the tools are just so much better. And if you look back historically at a single operation, we'll just say a single level lumbar fusion, and what 40 years ago, what the typical blood loss might be, what the typical length of the surgical procedure might be, and compare that to today, and it's night and day. It's losing a pint of blood and losing an ounce of blood. It's taking 4 or 5 hours in the operating room to taking an hour to 2 hours in the operating room. So it's really been a phenomenal advancement in that sense. But the holy grail, which Shree alluded to, which is making the diagnosis, identifying the pathology, and conceptualizing what the fix is, and then carrying it out. I mean, that still is the goal that we've all been laboring, to achieve, for as long as spine surgery has existed.
Really cool to hear those advancements. So thank you. Okay, with that, let's dive into our live questions from the audience. And whoever wants to jump in here, feel free. I'll go ahead and read the questions and we can get them answered. So the first question here, this person is wondering, are lumbar disc replacements becoming possible or any more routine? What is your opinion of synthetic disc replacement?
I can jump in. Sure. The disc replacement, the idea around disc replacements has been around for a really long time. In the cervical spine, I think we've made some real progress. I think not everybody is a candidate for a disc replacement. Ideally, it tends to be best for people with soft disc herniations and primary complaints of arm pain or the sciatica, what we call radiculopathy. It tends to be the ideal candidate. In the lumbar spine, I will say that it's not widely adopted in the United States. There are a handful of centers that really specialize in it and really kind of promote it. For better or for worse, they tend to be a bit invested in the technology, let's say, like they were involved in developing it and so forth. The most spine surgeons in academic programs for sure don't do it. And the reason that we don't do them is because the devices themselves have not achieved a level of maturity where you feel comfortable putting it in a patient. We don't really understand the longevity of it. They were very common in the 90s and the 2000s. There was a lot more enthusiasm, then there was a whole host of complications related to extrusion or these things coming out. And so there is a lot of development on it, but everybody is much more ginger about it. So I would say if you're really keen on getting a lumbar disc replacement, there are a few centers in the country, not many, that still do them, one in Carolina, one in Dallas, but you have to really like go out of your way to find it. Most spine surgeons don't do lumbar disc replacements in 2023 going on 4. Hopefully that'll change.
Okay. All right. Well, thank you. Okay. No, you mentioned radiculopathy. Question here for you. How successful is spine ablation for radiculopathy?
So I think that refers to one of the pain management techniques that are typically employed. And for whoever wrote the question, and most of the time that's done in Philadelphia, but done by an anesthesia specialist in pain, sometimes by a physiatrist, a rehabilitation medicine doctor in pain. And my personal experience is those procedures are sometimes beneficial for people with a lot of back pain related to degenerative joints that are on the side of the spine. May not necessarily help a lot with the radicular component. When I hear radiculopathy, I usually think that's a surgical problem in the sense that it implies that there's a nerve root that's under some sort of pressure that requires that pressure be relieved. So at least that's my approach to that.
That's I think I totally agree with that. Sarah, can I add something just in case the audience is not familiar? Because this is a question that comes up a lot, actually. Like they want to burn the nerve. Like, what does that really mean? And I use this analogy that your spinal nervous system is like a tree. So the tree trunk is the spinal cord, and the branches that come off of it, like right when they're coming off the tree trunk, are the spinal nerves. And those branches then branch again and branch again. They work their way all the way down to your fingers. Depending on what branch it is, it'll go to a different part of your hand or arm or chest or back or leg or whatever. The nerve that they are talking about burning is a tiny little twig that comes off of the main branch. So you have the tree trunk, you have a branch coming off of it. There's a little twig right when the branch leaves that goes to the joint. When they say they're burning a nerve, they're burning that twig. You would never burn the whole branch because that would affect the motor function and the sensory function of that branch, which would have dire consequences. We, in fact, are trying to protect it. That's the motivation around surgery. Irritation of the main branch coming off of that we call a radiculopathy. That's the medical name for it. Problems with the spinal cord we call myelopathy, in case that's a phrase that's heard. But the nerve that they're burning is a little twig. I just want to point that out. It's like we would never go put a needle in or cook the main branch itself.
Okay, appreciate that clarification. Thank you. All right, let's jump to our next question here. This person is wondering if the bone in the spine is stabilized from pressing on the nerves, will this relieve the nerve pain?
I think that goes back to what Dr. Prasad had talked about earlier, which is the most important, in terms of outcomes of surgery. And you'll always hear surgeons tell us, and there is no guarantee. There's no surgery that's ever like 100%, right? The best outcome from surgery is when you can correlate symptoms with imaging findings, and that they make sense, right? And sometimes some additional diagnostics like EMGs or other studies. But the point is, what the patient's telling me, what I see on physical exam, does it correlate with what I see on imaging? And is there a surgery that could correct what I see on imaging that I could expect to make that better? In general, yeah, if the nerve that is compressed is the pain generator, and you do a surgery that is successful in decompressing the nerve, typically that pain will get better. If the pain doesn't get better, you either think to yourself, well, is there a different pain generator? And sometimes that answer is not as clear-cut as you might think. Like there are times where the imaging is clear-cut. You've got a young, healthy spine with a very single, large extruded disc fragment, and there's a very clear corresponding radiculopathy or nerve or sciatic pain, and there is no other imaging finding on, and the pain is clear cut, right? You can tell that patient with 99% likelihood they're going to feel better if you do surgery and take pressure off the nerve root. A lot of the patients we can see in clinic have disc disease and some degree of stenosis and nerve encroachment at every level in their neck or every level in their lumbar spine. And one level might look worse than the other, but their symptoms may be a little bit of a mishmash. Like it may be a little bit that they have a little bit of, L2, 3, 3, 4, 4, 5, and 5, 1 stenosis. That's all contributing to their pain to some degree. All right. And additionally, I would say it's worthwhile to note that even when compression has been long-standing and chronic, you can take pressure off of nerves and still be dealing with injured nerves. So what we call neuropathy. Like radiculopathy or myelopathy tends to imply pain or symptoms that are related to, in other words, appropriate symptoms because a nerve is being injured actively by external compression, as opposed to neuropathy, which is more of like an intrinsic nerve problem where a nerve is maybe no longer being compressed, but is sending inappropriate pain signals to the brain. And so nerves that have been chronically compressed for a long time can still generate neuropathic pain even after they've been surgically decompressed. And there really is no way to predict that. And so when you hear the terms failed back surgery or failed neck surgery syndrome, like that's what that is implying, is that you can sometimes do what seems to be the correct surgery for the correct pain generator and still be dealing with chronic pain issues. And so the answer to that question is yes. In general, if you have the correct pain generator and you do a surgery that successfully decompresses the nerve, generally that pain gets better. There is always some chance of chronic neuropathy lingering in the background and still having issues.
Okay. Well, thank you. All right, moving along to our next question here. Dr. Yassin, this one is for you. This person is wondering, what does the recovery from spinal fusion look like?
Well, the indication is the most important thing at any surgery. So if the indication is right, then patients would recover pretty well. And you have to take in mind how the patients are doing preoperatively as well, how functioning they are. But in general, we would say it takes about 6 weeks. We would say the incision heals up in the first 10 days, and they would be able to be mobilized the next day of surgery. And the back would be sore for a good month because it depends on the type of surgery. If it's an open surgery, we would split the muscle insertion from the bone, and this needs some time to heal back together. And that's most of the pain where it is coming from, basically. But generally speaking, we tend to say it's about 6 weeks where they also get a brace. Not all centers fit a brace to the patients. We do that at Jefferson, and they remain in the brace for about 6 weeks. And it's just a reminder that pay attention. You have some surgery going on here. Don't do any crazy movement, bending, twisting. Just take it easy for the coming few weeks. No heavy lifting as well. And again, the two most dangerous maneuvers, in my opinion, are bending your back and twisting, like doing a sudden twist.
Okay. Important things to keep in mind. Thank you.
Yeah, thank you.
All right. We are about to wrap up the evening. So let's take one last live question. And then I have a final question myself for all of you. So for the last question this evening, what is a lumbar microdiscectomy and when is it necessary? And whoever wants to hop in.
Sure. A lumbar microdiscectomy is a procedure in which a nerve in the lumbar spine is decompressed, in which a small incision is made and a minimally invasive retractor, either a midline retractor or a tubular retractor, is used to get down to the spine. A small window is created in the bone to expose the nerve and a piece of disc, which may be coming out of the disc space itself. That disc, if it's pressing on the nerve and causing compression, we go in, find the nerve, protect the nerve, and take out the disc fragment that's pressing on it. So that's why we call it a microdiscectomy. We use a microscope. I frequently use a microscope for that procedure. It's a surgery that takes about 20 or 30 minutes. It's usually an outpatient procedure. The biggest risk of that procedure is another piece of disc coming out of the same hole. And that risk is highest at the beginning. So we tell people, like, kind of take it easy for the first 4 to 6 weeks, no heavy lifting, bending, twisting. It's the most common spine surgery in the United States. So it's an incredibly common surgery. Most patients with a lumbar disc herniation and concordant nerve irritation or radiculopathy get better without surgery. So 85% of them traditionally get better within 6 to 12 weeks. And that's part of the reason we try conservative treatment first. If that fails, then surgery is a reasonable consideration, and you should talk to your surgeon about the utility of that and what it specifically entails in your situation.
Okay, well, thank you. All right, and for our last question this evening, I have a final question for all of you, but first I want to thank the audience for a terrific discussion and all of your questions. I know I learned a ton, but for my final question, I would love for all of you to go around and just tell me, what would you like our attendees to take away from this webinar? And are there any questions that you suggest patients ask their provider? So Dr. Holscher, we will go ahead and start with you.
Yeah. So I think if there's one takeaway that I know I take every time I do this this web, we end up talking. There's some common themes that always come up, and the one thing I'd say is, like, there is no, patients often want very simple, direct, scientific answers to questions, and sometimes there just are none. Sometimes the answers are not as straightforward or simple as you'd like. And every patient is different. Like, frankly, not to sound corny, but like every patient's a snowflake, right? There's no two that have the exact same circumstances, right? The pictures can look the same, and everything else can be totally different. And the surgical discussion that follows can be very different for the same pictures. And so I think you just got to keep that in mind and understand that, like, sometimes some of the answers you have don't have simple, straightforward questions, because this is not a simple, straightforward topic. In terms of questions that I wish people would ask more, I think we've touched upon it a lot. It's like, what can you do to avoid surgery? I think that comes up a fair amount in my clinic, and it's the things we've talked about today. But it's like, surgery is a good tool when we have significant symptoms that are causing quality of life problems. But of course, like, the best thing, it's always best to avoid surgery if we can, right? All of us would rather not have surgery than have surgery, right? And so, having that discussion early, whether it's with a surgeon, a physical therapist, a primary care doctor, like, what can I do now to try to avoid surgery, is probably the most important question.
Okay, well, thank you. All right, Dr. Koptupka, can you let us know of any questions that you would like patients to ask their providers?
Well, I would just to kind of go with the general theme. So there's an ad that used to play on radio and TV about cancer care in Philadelphia, and the ad was, where your cancer care starts matters. And so I'd like to just make sure everybody understands that that spine is, because it's so many patients have spine problems in our country, that it is important to realize where your spine care starts matters. And we are obviously all Jefferson physicians here. There are very good systems besides Jefferson. I'm not supposed to say that, but in the Philadelphia region, get to a major center for your spine care, because you'll get a multifaceted approach, not just surgeons. You'll get pain management. You'll get better diagnostics, better imaging, and the real message is, everybody can be made better to some extent. We may not be able to make everybody perfect, but there is great hope that any patient can be improved. And I think the key to that is, get to the right place first, and be consistent with your therapy, and persistent and hopeful, and you'll be better.
Absolutely. Seek the right care. So thank you. Okay, Dr. Prasad, any thoughts from you?
I think both of those points are excellent. I mean, I guess if I had to add something, I would second what both of them said. I do think where your care starts matters. I would say your problem and the management options have to make sense. I think there is a fair amount of snake oil in spine care. And there's a lot of too good to be true kind of stuff that people want to buy into, because why wouldn't you, right? But there is a fair amount of, let's say predatory behavior, like opportunism, I'll say, maybe that's a better way to say it. And your care has to make sense. I think go to a place, you have to make sure that the relationship you have with your doctors is trusting, like you trust them, they trust you. I think that's imperative, because as I think everybody has alluded to, like spine surgery is not perfect. I generally tell people failures in spine surgery are usually not technical failures. They're usually failures of diagnosis and decision-making. And so make sure that your workup is rigorous and thoughtful, and the planning around it is thoughtful, that you exhaust non-surgical treatment as a general rule, that you trust your doctors, and that you go to a place that has comprehensive care that can offer whatever you need, whether it's surgical or non-surgical.
Absolutely. Okay. And finally, Dr. Yassine.
Well, we all stress on the same point. What is the indication to have my surgery? What are my expectations? Have I exhausted non-surgical treatment options? Do I have any red flags that has to be addressed? And these are if you have a muscle weakness or a sensory change, myelopathic symptoms like gait disturbance, bladder, bowel dysfunction, and many other symptoms. And nobody does surgery voluntarily. And we always tell the patients, you can always go to surgery, but never come back from surgery. So I totally agree with the need of a comprehensive spine center. And like Dr. Prasad said, it's not about the technique, it's about the indication of surgery. And once you start with the surgery, unfortunately, you will just keep on doing revisions and revisions for an unindicated case. And this is mainly, in my opinion, what leads to a failed back syndrome at the first place.
Okay.
So
Well,
always ask, why have I done it?
yes, and seeking the right care.
Yeah.
So thank you. All right. Well, thank you again, Drs. Holscher, Dr. Kopka, Dr. Prasad, and Dr. Yassine for your time this evening. We really appreciate you taking the time, and a lot of great information was shared about back and neck health and treatments. And of course, thank you all for attending and submitting such great questions. We will be posting an event survey, so you can let us know your thoughts. Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. A recording of this event will also be sent to you so you can rewatch at your convenience. And if you would like to view other wellness webinar series, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from men's and women's health to robotic surgery to planning for pregnancy and much more. Well, if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening.